Good morning. So as promised, that's now the clinical aspects of thorax. And today we'll be talking about mediastinum and pleura, right? So that we'll see the diagnostic X-rays, CT, PAT scan, and the 3D reconstruction and much more. So let's start. Now see, parallelly what I'll keep on doing is, I'll be telling you some of the signs, right? The radiological signs. I'll keep on telling you those signs which are, these signs, they are for the diagnosis part. Today we'll also be going for the differential diagnosis, DD, differential diagnosis. That is when the structures, they look quite similar, so then how to identify whether this structure is say thymoma or whether it is a germ cell tumor, right? So I'll be telling you something about those conditions so that you are a bit oriented with what we are talking about, plus the diagnosis part. All these things, they are part of the questions of any of the competitive exam, because that is, as it is said, that now you cannot cram, right? They will never ask you that list number of structures which are into the anterior mediastinum. No, they won't ask such question, but they can ask, they can show you a CT scan, they can show you one of the X-ray chest, and then they say, okay, what's the probable diagnosis, right? So that's how things would really go. So let's start with mediastinum, right? We could have started with lungs, but deliberately started with mediastinum. Reason? The most confusing topic, right? When it comes to lungs, carcinoma of lung or the benign tumors, it becomes very specific, right? It won't be that difficult. Pneumothorax, yes, it's a very good topic. But once you have understood mediastinum, rest all the topics, trust me, they'll be so easy. So we know that what mediastinum is. Mediastinum is nothing but what is present between two lungs, correct? That's the lung. This is the portion of mediastinum. At the junction of manubriosternal junction, that is the angle of Louis, this above, we'll call it a superior mediastinum, right? And that is, and this one below would be the inferior mediastinum. From the lateral aspect, when we see, right, that's the chest, that's the spine. So from the lateral aspect, the portion which is consisting of heart and all the vessels, that is the middle mediastinum. In front is anterior mediastinum, and what is lying below or the behind is the posterior mediastinum, right? We'll see it in still more detail, but this is in general. So the point is that over here, the connective tissue, right? This connective tissue will be in continuation with, it will be in continuation with the neck, correct? It will be in continuation with the root of neck, continuation to root of neck. Now when it is in continuation with root of neck, any of the infection of the root of the neck, it can spread below. Now straight away we go for the clinical part. Penetration wound, right? Any of the penetration wound, when it penetrates, right? Or when the esophagus perforates, right? So esophageal perforation. When this is happening, what really happens? These are the structures which are into the middle mediastinum, right? So when they will be involved, it can lead to the infection of mediastinum, and we can say it like mediastinitis, inflammation, correct? And this leads to one very interesting thing, and that is what is called as the subcutaneous emphysema, right? Subcutaneous emphysema. And we'll actually see that where exactly it leads to, how it really leads, right? So it leads to, this is what is called as subcutaneous emphysema. If you really say, okay, what exactly would be the definition? Well, definition is very simple. Subcutaneous is under the skin, right? So that means over here, the air it just gets into the tissue under the skin, right? So air gets into the tissue. Now I am writing only the keywords and immediately we'll see the example. Gets into the tissue, and this tissue is under the skin, right? Under the skin. Now it makes sense, right? So when we talk about when there is penetration wound. So yes, that air can leak out and it can go under the skin. Esophageal perforation, just from underneath, right? Esophagus perforates and it can go up. So basically, this is something which can be caused by one, it could be a surgical injury, right? During surgery, or it could be trauma, right? When we talked about penetration injury, trauma, or it could be infection. These are three very common things, and sometimes it can be spontaneous. That means where the reason, sometimes reason is not found. Say for example, bulla, right? It is called as the bulla. Bulla is a small opening, a small portion where the air escapes, it gets trapped, right? This is when we'll be discussing in detail tomorrow about the pneumothorax. So this is how it can really occur, right? Now, can we really see it? Yes, we can see it very specifically. We can see it, right? Say we'll see it on CT scan, right? One, and we'll see it on the simple plain X-ray chest. Now, before we proceed for that, right? CT scan, where we can see the tissues, right? We'll be able to see the tissues and we'll see the air in the form of small bubbles sort of thing, right? We'll see that image. In case of X-ray chest, how it will look? It will look black. Why should it look black? Because see, it is air, right? It is air, and through air, X-rays they can pass easily. When the X-rays they hit the photographic plate, it turns black, right? It turns black. Think it like bone, right? Bone, right? If the bone is there, X-rays they won't be able to pass through it. So that's why over here bones they appear white, right? Just that's the basic. That much is you understand. And see over here. Here is the CT scan, right? This one is the CT scan. Today there are lots and lots of images, right? So see this portion, right, where the arrow is put. So this is subcutaneous emphysema, right? This is subcutaneous emphysema. Now, no doubt, just from the looks, immediately you must have identified all these. These are nothing but they are the abdominal loops, right? That's the kidney which can be seen. So this is CT scan abdomen. So the idea is about this subcutaneous emphysema. Subcutaneous emphysema can occur at any of the place, right? Depending upon where the injury is. So over here, see the below. This is where it can be seen so effectively, right? So cleanly. So this is what is called as the air in subcutaneous or the subcutaneous tissue, right? Now let's see from the perspective of thorax, right? This is a very nice X-ray. See this. Now you have seen the normal X-ray chest. Right? This is X-ray chest, PA view, right? Immediately you'll know that it is the right side, right? It is the right side which is at fault. There are some very major things in this. The first thing first, this is a normal lung, right? Look at this and look at just don't worry about the ribs, right? Just look at the lungs. Over here, lung itself is shown like it's not that black, right? It's not that black. Is it painful or uncomfortable? Very painful. Yeah, it is painful. Because when the air gets trapped, so actually you have to just cut and you have to really say release it. Yeah? It is painful. Achha. What I was talking about? Yeah, look at the lungs, right? Look at the lungs. The left side of the lung, it looks like, because after watching few of the X-rays, immediately visually you'll say, okay, this is normal, right? This is normal. This is okay. However, on the opposite side, right side, there is less of the blackness. when the blackness is red, that means air is less, right? That means air is less. So if the air is less, so that means that airspace has been taken over by someone. Now this is more whitish, right? It looks like white, and it is quite irregular. But can you see the bronchovascular markings? Beautiful, right? See, so many bronchovascular markings, right? They are seen so prominently. Let me zoom it and show you, right? See, no doubt about it, right? See, all the way, right? See, all the way, right? You can see. So what it is? It is what's called as, there is injury, to the lungs, right? Injury to the lungs. So because of that injury, because of that trauma, blood and fluid, it has got accumulated into the lungs, and that's why the air has been displaced. So there is air plus the fluid, blood and fluid. So that's why this is looking this. So this is, now there are other signs also, and we are coming to that, right? So this is called as the pulmonary, remember the word contusion. Contusion is nothing but bruise or bruise, right? We get the bruise mark. Sometimes we get the injury, a bruise mark. So this is that, right? And why should it occur? This is very typical. There are two things. One, what is called as the pulmonary contusion, and second is pulmonary laceration. Laceration is when the lung itself is cut. It's like a stab injury, right? And then it is cut. So means it is totally ruptured. This is not that. This is classical of blunt injury. Blunt injury. Now, when there is blunt injury, this particular X-ray tells you something very, very beautiful thing, very worth understanding. Blunt injury, and it is a chest trauma. Chest trauma. So that means there is injury, but there is no cut, right? There is no cut. Due to which, what has happened? Blood and fluid, right? They have displaced and they have been accumulated in lungs, and that's the appearance. Now when we do get such type of injury, classical thing, classical traffic accident, right? Car accident. Say when we wear that belt, seat belt. So when suddenly you apply the brakes, if the brake is applied, right, the body will keep on moving because of that motion, principle of motion. So the impact of that brake, then the whole body goes in front, right, and it hits the chest. So if someone is driving, that steering wheel, it hits the chest. Now this is a blunt injury. Yes, that's a blunt injury, right? And that blunt injury can lead to what's called as the pulmonary contusion. Now why when such patient comes, you will be surprised when those patients come, they'll be coming with very good condition. They'll just say, "Ha, there is pain," and they'll be like gasping. But as such, you will not find that okay, there's some major thing has occurred. If someone is bleeding, you'll be giving more attention to him as compared to someone who is coming with this particular condition. Now see what has it. So I'm just writing traffic accident, right? Traffic accident. And therefore those seat belts, right? Seat belts, right? They are so important. So sometimes when I see medicos driving without wearing the seat belt, I really tell them, yeah, it can be hemorrhage too. But see, more is yet to come. Seat belt or those airbags, why they are so important? It is because of this. Now, being in medical science, right, one should definitely wear the helmet, because when we'll be discussing head injury, you'll say, now to this, when we are studying this topic, right, we should wear the helmet. Right? So it's that dangerous. So this is one. Now we come to something which is very, very serious. By the way, this is one point. This second, you can just judge by yourself, right? Can you see this? See this side of soft tissue completely black, and in between, right, you get all these irregular margins which is into soft tissue. Nothing, but it is what? It is subcutaneous emphysema, right? Subcutaneous emphysema. So from this looks itself, now you are almost certain that this is a case of accident, right? You are right. So this is the air in soft tissue, right? Air in soft tissue. Otherwise, soft tissue should look with very proper margin. See on this side, right? See on this side, right? Such proper margin. But over here, it is all irregular, rough, right? Because air has entered into it. This is where there are multiple, see that, multiple fractures, multiple ribs are broken. Can you really see this, right? Multiple ribs, multiple, badly broken, right? See over here, so it is just split into two. I'll just zoom this thing so that you can watch every injury. Right, pretty zoomed. See, first one. Can you see? See, this is the margin of rib, and over here. See, this is the break. Over here, this is the break. The another broken piece is lying like this. This is the break, right? See this one, it is even displaced. This is one piece, and this one is the second. This is the break, right? Another break. See this, very typical, right? But it is not mal-aligned. It is, alignment is okay, but otherwise it is broken. Over here, this lower piece has gone completely down. Yeah, it's completely broken, right? So now what I'll do is, see, I have marked, right? I'll remove now these markings, and so that you appreciate it. See this point, right? Then watch this. Can you appreciate that? See, the rib is broken, right? Can you appreciate that this rib is broken? I'll just remove this over here. Here the rib is broken, right? See, here it is broken, right? Totally malaligned, right? Over here, broken, correct, broken. Here also, see, this rib is also broken, seventh one, right? So complete breakage, right? So multiple breaks, even this one, here it is, here also it is broken. So 1, 2, 3, 4, 5, 6, 7, 7, 8, right? Multiple ribs, almost. Well, we are coming to that, Pranjal, right? What will happen when the ribs are broken? Okay, so this is what is called as the flail chest, right? It is called as the, remember the thing, flail chest. When the chest is broken, right, multiple ribs are broken. To appreciate it still better, right, now see this, right, and then we'll talk about this. This is CT scan, right? This is CT scan, yeah, but it is 3D reconstruction, right? CT scan, 3D reconstruction. Now in 3D reconstruction, you can really watch it from all the sides that the ribs are broken at not one point but at multiple points, right? At multiple points the ribs are broken. Now when the ribs are broken like this, right? When the ribs are broken like this, it leads to as the complication, right? It leads to the complication, and that is that those broken ribs, right? Those broken ribs, what will they do? Broken ribs, their ends, they are always, yeah, patient should not be moving much, that's true. But those broken points, right, they are very pointed. So they pierce pleura, right? When they pierce pleura, the moment the pleura is pierced, so we watched last time, right? When that seal is broken, immediately air enters into it. So that leads to what? That leads to pneumothorax, right? And when the pneumothorax occurs, that is when air enters into the pleural cavity, immediately lung feels like, let me collapse. And yes, that is what is called as the lung collapse, lung collapses, right? So that's very right what you were telling, right? When ribs are broken, lungs get collapse or not? Definitely they collapse, right? Because the moment they injure the pleura, this is the reason what you wrote is very right, that as far as possible, patient should not move, because who knows that which end is piercing what pleura, because sometimes if the pleura is not ruptured, it is easy to follow. What will you be getting? You need to watch for one very important clinical sign during inspiration, right? This is something which you have to just watch, right? During inspiration, right? Learn it very crisp clearly. Inspiration is an active process. You breathe. When you breathe, the size of the chest is increasing, right? So chest size increases. Chest size increases. When the chest size increases, so that means there would be negative pressure inside. So air goes inside, right? Air goes inside, right? So when we say, right, so it is like, because the pressure is so much, you have forcefully, you are in doing the inspiration, so air rushes in because chest has expanded, diaphragm has contracted, so everything is down, big chest, right? But over here what happens is that we'll call this chest as flail chest. Flail means, just understand that broken piece. So in this case, let's say this is the flail area. Flail area means that area of the chest which is broken. When the ribs are broken, so that piece is separated. Right? This piece is separated. This piece, it won't expand. In fact, it would collapse. Right? This flail chest would collapse. It would go down. Right? It would go down. Similarly, during the expiration, when we breathe out, so then chest shrinks, right? The chest shrinks. So chest shrinks. So air goes out, right? Because the diaphragm is pressed up, abdominal organs are pressing the chest, right? Chest is collapsing, lungs are always interested in collapsing, right? So air goes out. So at that time, this flail, broken portion of the chest, that also tries to bulge out, right? That tries to bulge out. So this thing is one of the classical, what is called as the paradoxical breathing. It is called as the paradoxical breathing. Paradox means it behaves ulta. It behaves opposite. It behaves opposite. So during inspiration, when the chest should expand, this piece will go inside because it is not connected with the chest. So it won't behave like the chest should behave. So it will remain there only. So rest of the chest will expand. So this relatively, this piece will go inside, right? So pressure does not develop in flail lungs during inspiration. True, true, because of that injury. And during expiration, when the chest, right, when the chest should go down, the rest, this broken piece, that will remain there. So it will appear as bulging. This is paradoxical breathing. But remember one thing from the clinical point of view. Sometimes there is flail chest, but still you don't see the paradoxical breathing if the patient has come in a very early stage, right? So this is a bit late sign, but if it is present, right, if it is present, be alert, right? So absence of paradoxical breathing never rules out flail chest, right? So that's why depending, the radiological importance is massive. Once you go for, say, this, and this can be seen on even some simple plain X-ray chest, right? So that is what we learn from it. Treatment part. For the treatment part, so it is all first, so depending upon what is called as the airway, breathing, and the circulation. These are the things which we have to manage, right? And so obviously the oxygen, and then don't let him move, and all the ribs which are pierced, they have to be surgically corrected. That's right, that they have to be surgically corrected. In case if there is any lung perforation, so that has to be taken care of. Depending upon what injury, if patient is into, say, shock, so that treatment of shock. If there is any, say, blood loss, so then you have to take care of the fluids. So depending upon whether you give ringer lactate or you give, say, normal saline. So depending upon you have to treat the patient as per his symptoms, right? And yes, all these things, they'll require surgical correction. Now we move on to the mediastinum part, right? Mediastinum part. So first, let's see what are the structures. What are the structures in mediastinum? As you will come in clinics, as you will start studying the pathology, the most confusing thing is when the topic asked is mediastinal tumors or the mediastinal space occupying lesion. SOL means space occupying lesions. Now it's a huge list, right? Lesions. In fact, in radiology, you can study this topic for almost a week. Trust me, for even after 1 week, I would say that still few of the conditions, rare conditions we are not talked about. So what we see is flail chest, subcutaneous emphysema, pulmonary condition plus broken ribs. Yeah, that's flail chest is okay. Flail chest is not equal to flail chest is equal to broken ribs only. Subcutaneous emphysema, it might be present, it might not be present. Pulmonary contusion in this case, right, it is present, but every time it might not be present. But usually it occurs. But when we talk about flail chest, it is broken ribs, right? So over here, let's be clear, right? This is what we said, that there are three things you find: pulmonary contusion, that is one; subcutaneous emphysema, that is second; and flail chest, that is third. Got it? Right? So that is the thing. So these are the structures. So first, let's see the structures which are present in anterior component or the anterior compartment. See these structures. One, take care of thymus, right? Then say internal mammary vessels, that's fine. Lymph nodes, right? I'm not say talking about all the structures, right? Say they are present, but today we'll be emphasizing on that what are the commonest things which we see and how can we really diagnose. And trust me, you'll be diagnosing some of the very classical things very easily, right? So lymph nodes. Then lower pole of thyroid. That's right? Thyroid, lower pole, right? That would be coming over here. And ectopic parathyroid. Normally parathyroids, they are not present over here. Ectopic, right? When abnormal. So right now we are not talking about it. We just focus on things which are completely normal. Thymus and lymph nodes, they will be comprising of almost 75% of the space occupying lesion, not even the lower pole of thyroid. Thymus and lymph node, right? And we'll see that. So this is the anterior compartment. The second compartment, which we call it like a visceral compartment, right? So this is one anterior, visceral, which is the in between. Beyond doubt, right? You know it so well. Heart and pericardium, no problem. Great vessels, that is all great vessels, ascending, descending aorta, aortic arch, right? Supravena cava, inferior vena cava, pulmonary trunk, all of them, including the azygos, all are there. Great vessels, right? All are present. Then either ligamentum arteriosum or patent ductus arteriosus, whosoever is present, right? So arteriosum, ligamentum arteriosum or PDA. Thoracic duct would be present, right? This will be where there would be vagus, right phrenic, left phrenic, and the recurrent laryngeal nerve. So the recurrents, they are present. Lymph nodes, they would be present over there, and the anterior surface of vertebral body, because that would be the level, right? But see, visceral compartment, that is where most of the vessels, heart and the thoracic duct, right, they are present. The third component, the posterior part which is just posterior, right, where there is lateral surface of vertebral body, and there would be important thing, sympathetic chain and its ganglia. So that means anything space occupying lesion, if it is in posterior compartment, most of the cases it would be neural. Correct? It would be neural, because sympathetic chain and ganglia. So all these schwannomas and all those things, they will be occurring over there, right? We'll see that, but they will be occurring over there. Otherwise, so they are rest of the components like posterior costal segment, that's okay, right? Those ribs, posterior segments, they are there. Intercostal vessels, intercostal nerves, that's fine, but these two are more important. Regarding the in between, heart. So anything related to heart, anything related to pericardium, anything related to those vessels, right? All of them, they are related to visceral compartment, and in the anterior thymus and lymph nodes. That's what we see. Just remember this much, and you have learnt almost the complete mediastinum and its associations, right? So what we'll do, I'm giving you one very small guideline how you have to approach whether the patient is in front of you or you have got his reports. So it means what you have to ask, right? Any of the further clinical features, always watch for one. Is that how is trachea? Because it is very easy to see trachea, right? You'll be able to see whether the trachea is shifted or not, right? Whether the trachea can be seen or not. So is the trachea compressed? Is the trachea compressed? Right? Trachea compression, how will you see? So simple. See, that's the lung, right? One side of the lung, and here is our trachea, right? So I'm drawing the trachea in green color, green color. Now, if there is any tissue, if there is any cancer or any of the space occupying lesion from the lungs, right? This is from the lung inside. This would be the shape, correct? This would be the shape because trachea, you know, it is flexible, right? So that shape would push. So the real shape of now new trachea would be something like this. Because we saw that trachea is compressible, right? Trachea is compressible. So trachea, it is flexible, right? We saw that, right? So this would be the shape when it is pushing from inside. But right now we are not dealing with it. So this would be the lung mass. Lung mass. Anything which is coming out from the lungs. So carcinoma. And what if it is from lungs? So inside, right? Inside it, if this is the mass, inside it we'll be able to see the bronchovascular markings because it is lung tissue. Make sense, right? So BVMs, bronchovascular markings, they would be present into this. We'll see all this into this space occupying lesion. Watch the reverse thing. Same lung, right? Same lung, right? And over here, that's the trachea, right? And when I say trachea and then those bronchus, everything. This I'm just drawing trachea for the simplicity. And now there is mediastinal tumor. So mediastinal tumor means that is present into the mediastinum. Now because of the structure, most of the tumors, right, such tumors, space occupying lesion, they are into anterior part. So when they are anterior, right, and they'll push the trachea on one side. So now this one, right, now this one would, right, would develop, right? This is a tumor. This is a mass. Now this particular mass will not be having, it is not emerging from lungs, so it will not be having any bronchovascular markings. So BVMs, first thing, BVMs, bronchovascular markings, they are absent. Yes, so this tells that it is definitely mediastinal tumor. And second, what would happen to trachea, right? That trachea, that would now be shifted like this, right? Because it is pushed like this, right? So this is how it will look like in both the things. So we'll see the x-rays of it, right? So this is mediastinal mass, right? It is mediastinal mass. And when we say anterior, so in anterior, so there is thymus and lymph nodes. That means it could be either thymoma, that is the malignancy of thymus, or lymphoma, right? When the lymph nodes are enlarged. And for the lymph node enlargement, what is the best thing? We'll do the FDG PAT scan, right? Fluorodeoxyglucose PAT scan. So where it will be shown that which are the lymph nodes which are metabolically more active, and we'll be able to see that. We'll be able to see all the lymph nodes, even if they are extending into the neck, we'll be able to see that, right? We'll see all these cases, but what should be our approach? That's very important. So first, you'll always look for the trachea. Second, you will watch, or let me write it here, right? I'm writing here, esophagus, right? So ask the patient, or is patient telling that I'm having difficulty in swallowing, right? So is he having difficulty in swallowing? And sometimes you have to go for what's called as the barium swallow. Barium swallow. So when you see the barium swallow, you'll be able to see the sorry. So you'll be able to see the compression on the esophagus, right? The third important thing which you have to watch, how is the cardiovascular system, CVS? Say we'll be watching pleural effusion. Right? We'll be watching pleural effusion, and we'll be discussing pleural effusion from the medical point of view, medicine point of view, right? That whether it is because of the transudate or it is because of the exudate. Because the moment you check it, if it is transudate, then it is very clear that either the heart is involved, either the kidney is involved, right? Crystal clear. When it is exudate, you know that it is because of the local region. It means there is something wrong in the lungs. So even those lab reports will help you a lot. Just by looking at the protein content, you'll immediately know that what exactly are you talking about. So watch for CVS, cardiovascular system, right? So this is when tomorrow I wish to even take a small session on how to examine the thorax, right? Inspection, palpation, percussion, and auscultation. These are the things, these are the 4 steps, right? Let's see, right, how it gets, but we'll take one session on that. This is purely this session. That session would be purely clinical, right? No way any of the first year or student is expected any one of those things. But once you'll know, it will appeal you so much, right? You'll be very happy. So this is watch for the cardiovascular system. And the fourth thing is watch for the nervous system. Nervous system. So is the patient complaining of any of the dizziness, fatigue, any of the pain, right? All those nervous systems, these will give you one clue, right? And on top of it, always ask for, is there any fever? This is non-specific, but will give you an important hint, right? So is there any fever? Once you know this, right, then you go for the lab tests. And then blood has been sent, and now you will be going for radiological investigations. Radiological eye-axis investigations. So commonest, X-ray chest, right? Then you can go for ultrasound or CT scan, right? Or MRI or PAT scan, right? All those things, they can be done. After that, you can even go for scopy, that is bronchoscopy or thoracoscopy, right? All those scopies, they can be done, but they are invasive, right? So scopies can be done, right? Bronchoscopy, etc. So that's how we proceed, right? Okay, let me add one page. So before watching straight away the space occupying lesions into the mediastinum, let's watch that in case of anterior mediastinum, what should we really look for, right? And I'll give you one complete diagnostic approach about how to really diagnose, and you'll be able to diagnose, right? So in anterior mediastinum, we said that one was thymus. Then very simple, there could be a cyst, thymic cyst, a fluid filled, clear fluid filled cyst, very well defined, round. Do we have any window period for it? window period for window period for sooner the better in any of these conditions, because all these are emergency conditions, right? If you are asking for that flail chest, so then yes, it is as early as possible, right? So one is the thymic cyst, right? When there is a fluid filled cyst clearly defined and you'll be able to see it. Then could be cystic thymoma. Thymoma, whenever this is oma, right? This is tumor, right? There could be involvement of lymph, so lymph nodes. So this is lymphoma, right? A tumor of lymph, right? Or a very interesting thing, it is what is called as the GCT, or the giant cell tumor. If at this level, at any point of level, if you can diagnose these things, right, you are superb, right? What about the middle mediastinum? What can really occur? Now you know that in medial mediastinum, what is present, right? Esophagus is present, pericardium is present, vascular, all those great vessels are present, thoracic duct is present, right? So what could it be? It could be some congenital anomaly, so in the form of, let's say, esophageal duplication, right? So there can be esophageal duplication. For this, we have to learn a bit about the embryology. But well, esophagus, the duplicate esophagus, or it could be, this is like pericardial cyst, right? Pericardial cyst. In pericardium there is cyst. Or what we talked about is vascular, right? Or those great vessels. So just in general, we write vascular masses. What can really happen? Aneurysm can happen, right? Aneurysm can happen, so that there is bulge, right? Or thoracic duct cysts, right? Because that was the structure. So thoracic duct cysts. So these, you just from the structure itself, you know that these are the things which can occur. And in the posterior mediastinum, right? Posterior mediastinum, we talked about that most of the neural tissues will be there because there is sympathetic chain, right? So most of them, they'll be neural. So in neural, there can be, say, neuroblastoma, right? Blastoma tumor, right? Then there could be ganglia involved, so it would be called as neuroblastoma. So easy, right? Now, because right now we are not discussing all those neural tissues, but when we say neuroblastoma and the ganglioneuroblastoma, it means ganglia is also involved, right? There could be fibrosarcoma, right? During pathology, everything would be discussed at length, but this is in general giving you the idea that what exactly can occur between all of them, right? Now let's see some of the cases, right? So it will make things very crystal clear. So immediately you'll say that this is X-ray chest, PA view, right? X-ray chest, PA view. And what we are watching one thing. This is, can you really see? Right, let me zoom, and here is the trachea, right? Here is the trachea. Let's take the another color, black. This is the trachea. Watch the trachea. Watch the trachea. Right? Can you see it is shifted on one side, right? And you are watching a clearly, right? See, sudden abruption, right? Another thing is, I'm taking it back to normal over here. Can you see a bulge? This and this. This type of bulge we don't see normally, right? This is definitely a lobulated, right? This is lobulated widening, correct? This is lobulated widening of superior mediastinum, because that's the angle of Loewe, right? So lobulated widening over here, right? Lobulated widening of superior mediastinum, but not mediastinum. Nothing more can be said about it. Just we can guess that this is definitely there is some space occupying lesion, right? So that's over here. So in order to see this thing, we have to take a lateral view, right? So we go for same patient. Now, this is the lateral view, right? X-ray chest, lateral view. Now in lateral view, this is posterior part, right? Because spine is there, right? This is posterior, so this is anterior. If this is anterior, that means this one, this portion, that is the sternum. In lateral view, sternum, and in lateral view, there is always a retrosternal space, clear space. There would be a retrosternal space, right? Thus, there is a space behind the sternum. Now, if you see, if this is the sternum, right? If this is the sternum, this is the space, right? This is the space where things should be watched. This should be clear. No, it is not clear. There is a clear presence of some structure, right? This, it is over there, correct? This is retrosternal space, right, is not clear. So I'm writing it in such a way so that you know that it should be clear. If it is not clear, that means there is some tissue which is into the anterior mediastinum, right? Now you can't straight away stamp on it that what exactly it is, because you have to correlate with the clinical sign symptoms. But now you can say that most probably it could be either the thymus or the lymph nodes. So it could be thymoma or it could be lymphoma. So many a times when you see the reports, so it is, the report is written like that, this there is suggestive of space occupying lesion in the anterior mediastinum, suggestive of thymoma or lymphoma. Clinical evaluation is compulsory, suggested CT scan, right? So that's how you go for this patient. Later on turned out to be thymoma. I'm sorry, lymphoma. This was a patient of lymphoma. It turned out to be a patient of lymphoma. So what is, say if it is lymphoma, so then that means lymph nodes are involved. True. If lymph nodes are involved, so this patient was then subjected to, same patient, huh? We are talking about the same patient, right? It's a complete sequence. Same patient. This patient was subjected to FDG PAT. FDG PAT, right? This is fluorodeoxyglucose. I'll write down. This is fluorodeoxyglucose positron emission tomography. So what it really does is, it does two things. One, it will detect, right? It will detect abnormally metabolically active lymph nodes. And how do you see that? In the report of this FDG PAT, you will see that it would be mentioned a bright spot is seen. Wherever you find this word bright spot, right, be alert. This bright spot, that means this is hypermetabolically active, then normal, right? Then normal. So can you really identify bright spots? See, not one, but many, as compared to the surroundings, right? You will find bright spots, correct? These are typical bright spots as compared to surroundings. See here, even here, right? So this here, in this area, so it is, the whole area is bright, right? Now I'll remove these arrows, right, so that you can Just figure out, yes, these are. I'll just mention this, like this. These are the bright spots. So can we say that these bright spots, they are metabolically active than normal? This is nothing but definitely lymphoma, right? So because this is active. Now, where do we really go for this, right? Because we want to see whenever there is carcinoma of lung, right, you go for PAT because it will tell. In this case, say this is AP and this one is lateral. This one is lateral. So you are watching that it is going up to the neck. This is neck. So lymph nodes, and this is anterior mediastinum. This is even the middle mediastinum nodes are there. Some of the nodes, they are into the posterior mediastinum, right? Very less, but there are. But most probably mostly they are into anterior and middle. So we have lymph nodes which are into anterior, middle, posterior, and they are extending even up to the neck. Right. So we'll see this, we'll do this thing into carcinoma of lung, CA breast, right? Very common reasons. Then obviously the lymphoma, right? Lymphoma, especially say in this particular case, right? Then colorectal carcinomas, right? So whether it has spread, or multiple myeloma. That's right. Because the metabolic activity is diffused. And yes, there are so many. That's why it was lymphoma. That's right. And obviously the blood report, lab test, they will also start supporting it, right? So this is how the conditions they really look like. Say my intention is that instead of sometimes we just cram, okay, antemediastinum thymoma, this, middle mediastinum, no, don't cram. Just look at the structure, whosoever the structure over there, only that thing can go wrong. That's it. You know? I should explain one more thing to you, right? This is still very interesting. This is I just watch the X-ray first, right? Just watch it, right? I'll just zoom it. It's for your visual impression, right? Visually, just watch that. What can you really see? And beyond doubt, immediately you will say that something is over here, है ना? Bas. And do you see? That's right. This is okay. SOL in right lung, right? SOL in right lung. Wait, right? We'll see. But yes, there is SOL, right? There is space occupying lesion, right? There is space occupying lesion. Watch for the trachea, right? So that means there should be something over here. No? Okay. Bas, this is what I was expecting, and now we talk about it. So here is the lung, right? And this one is hilum, okay? This one is hilum. So there would be the blood vessels, right? There would be blood vessels going along with it. There would be arteries, right? There would be arteries, and there would be even the primary bronchus. This is our hilum, right? It is hilum. Now, if there is a mass which is on it, right? When it is a mass, if there is a mass, oh, it's too big, right? Let's make it small. Now this, okay. If there is a mass on it, so then what would happen? You will see a completely normal hilum, completely normal hilum, but the mass is seen. So whenever you see a normal hilum and that you are watching through any of the lesion, this means that this mass is not in hilum. This mass is not in hilum, right? It is, in fact, it should not from hilum. If we write, that would be more apparent, right? It is not from hilum, because if it is from hilum and if it is expanding, so it would shift all the structures, right? It would shift all the structures. Here the hilum is seen properly. Trachea might be affected because slightly moving across. Okay, when you see this thing, right? When you see this thing, this is like a small cheat. Yeah, so benign. That's right. It could be high and malignant, but yes, initially, benign chances of benign are more. That's right. So mass is not from hilum. So most of the mass, if this is the situation, are in anterior mediastinum. Anterior mediastinum. Remember this, right? You will be, in most of the cases, you'll be right, subject to if someone has put a very crazy case, but at UG level, it never happens, right? So this is, so like you can take it for granted that whenever there is a mass in the hilum and then you can see the bronchovascular marking, hilum you can see properly, definitely this is an anterior mediastinal mass, right? Now in the mass, you won't be watching any BVM. So over here, that is, this is the mass, right? This is the mass, and in the mass, no BVM, no bronchovascular markings. True? Right? No bronchovascular markings. And you can see the shift of trachea. Right? Shift of trachea. Bas, enough we have discussed, and you'll be able to see so nicely. And yeah, this what we talked about, it is called as its name is called as this thing is called as the hilum overlay sign. How easy it is, right? Hilum overlay sign, right? Hilum overlay sign, it is on the hilum. So now see this trachea. This is the trachea, right? That means something is over here. If something is over here, there are no BVMs, no markings, no bronchovascular markings in mass, right? That means definitely this is mediastinal mass. Another thing is, if we see, we just remove all this entire portion, right? It is quite big. In fact, it is quite big, right? Quite big. So through this mass over here, if we just for few seconds, if we just forget about the mass, we can see that the lung is completely, very nicely, all the bronchovascular markings, they are seen fully, right? Sure, right? See, this is the trachea, right? The trachea is shifted over here, right? Trachea is shifted. This shape itself tells that there is something over here, you know? So when you see the hilum overlay sign is that you are watching that there is a mass, right, which has shifted the trachea, which has shifted the mediastinum. And another thing is, this mass is big, and through the mass into the region of hilum, because this is the region of hilum, this is the hilar region, right? This is the hilar region. This mass is big, so it is right from the here, right? It is involving this area. So this is hilar region. If you watch that in hilar region, you can watch all the bronchovascular markings. See, right? As if this is a completely normal lung. So normal lung, and on it's this hilum is superimposed by this mass, right? So whenever you get such type of thing, most of the cases it is anterior mediastinum mass. Because see, we are watching a PA view. In PA view, whether this mass is posteriorly situated into the middle or to the anterior, three possibilities are there, right? So can it be schwannoma, right? Straight away into the posterior mediastinal mass? No. Most of the cases when you see this structure, right, this appearance, it is antemediastinum, right? Because those things, they are a bit rare. So this is the commonest one. So two things you are watching: one, tracheal shift, and second, no bronchovascular markings in mass, and the hilar shadows, right? Hilar shadows, they are seen normal. Shadows are seen, right? Seen normally. Hilar shadows can be seen, right? What will you do? Right now this is the best is go for CT scan. Just one cut and done. You are through with the diagnosis. So this is our X-ray chest, right? X-ray chest, and we always take a PA view because that also tells that this is, right? Got it? Sorry. We go for CT scan, right? So that's the CT scan. And the moment you do the CT scan, such a big mass, and that's the mass, right? Where is the hilum? Here is the hilum. Here is the hilum, right? Got it? This is the hilum. And this mass is superimposed. So that's why when the X-rays, they were passing through it, we were watching this mass superimposed on the hilum, and that's why it is pushing the trachea on the opposite side. All settled. Same patient, right? Same patient. And when it is into the antemediastinum, again, back to same. It could be thymoma. It could be lymphoma. The size itself is telling it cannot be thymic mass. It has to be lymphoma, right? This is the thing. Such huge mass, right? I'll show you even thymic cyst and everything, right? We'll see that. So this is how we really look at the picture. Now let's understand that what are the other tumors. Now see, in anterior mediastinum, I'm giving you some of the cheat codes, right? In anterior mediastinum, and trust me, when you diagnose it, right, it would be super impressive. If there is a cystic mass, right? If there is a cystic mass, what do you mean by cyst? Cyst means fluid filled, right? Clear fluid filled. That's what is called as the cyst. Cyst, right? You know the blisters, right? Currently, I'm having 4 blisters in my foot because I used new shoes while running that marathon. So still those blisters are there. But those blisters, if this is your big toe, right? That's your big toe. So then you get a blister. So the blister will be having what? A clear fluid, right? So this is like a cyst, clear fluid, right? Remember that. So now this is from the CT scan approach, right? We'll be watching only the CT scans, right? CT scan approach. From X-ray chest, you have come to that conclusion that it is the anterior mediastinal mass. And you do the CT scan, even one plate would be sufficient. If it is pure cyst, right? That means there is just clear fluid and nothing is into that. Those, trust me, this would be the thymic cyst, because such clear cyst, it is seen only in that. Lymphoma can never be seen like a complete clean fluid fields, right? When you see cyst with solid, with some solid structures. This is where think of that you are dealing with lymphoma, right? Or it could be cystic thymoma, the tumor. This is more dangerous. This is more dangerous. This is carcinomatous, right? Surgical removal is must, right? So this is malignancy, right? I'll just write malignancy, both of them, right? Malignancy. Which one of these are easy to treat? Well, depends on what's it. Thymic cyst is the easiest, right? Just a surgical removal, easiest. Lymphoma and cystic thymoma, so they are malignancy, right? So you know the malignancy. So depending upon what stage it is, so you have to go for chemo or chemotherapy, radiotherapy, or the surgical intervention, depends, right? And the third is GCT. GCT is germ cell tumor. And this is a huge topic, germ cell tumor. But when you see this thing, right, the appearance is very classic. Okay, cyst with solid, let me write it like this. Cyst with solid, over here you'll see cyst with septas, right? Cyst with septas. Septa means partitions, right? You'll see the partitions, they are like partitions, and these are like enhanced partitions, right? You'll be able to see it very bright, very prominent. So this would be the GCT, diagnosis would be the GCT, germ cell tumor, right? Germ cell tumor, we'll talk about it, right? Don't worry, germ cell tumor. So basically these are the cells, these are the tumors, which is the growth of cells which are from reproductive cells. Lobules, that is in septas, you'll see that, right? Typical septa. So thymic cyst, lymphoma, and cystic thymoma, they are malignancy, and this germ cell tumor. See, if we just speak about a bit about germ cell tumor, right? This would be very helpful. This GCT or the germ cell tumor. See, the whole life starts with those basic primordial cells, right? Primordial cells. In fact, they are called as the totipotent, right? Totipotent. It means that they can be anything. Totipotent, primordial, germ cells. Life starts from that. And then they start developing, and few cells they become tissues, few cells they become bone, and the whole process continues. If they are normal, so they lead to formation of normal testis or normal ovaries, right? No tumor, right? There is no tumor. This is normal. But if anything goes wrong, right, at the embryonic stage, right, at the embryonic stage, because things can go wrong either in embryonic stage or extra embryonic or germinal state, right? So in the embryonic state, if it is somatic, so that leads to teratoma. All these are the pathologies. Now from OMA, immediately you would be able to identify, right? Or straight away it can lead to embryonic carcinoma, right? Embryonic carcinoma. This page would be very important, right? When, as we'll be discussing these things individually, immediately things will become more and more clear, right? Extra embryonic, right? Extra embryonic, when we say, so two things. One is the yolk sac and second is the chorion, right? So this is yolk sac. By the way, how much have you guys studied about the embryology part? Just asking so that I can talk with reference to that. How much have you learned the embryology? The general embryology, right? All the way up to at least say 6 to 8 weeks. Just let me know, right? Okay, so the yolk sac tumor or choriocarcinoma, right? Choriocarcinoma, CA is carcinoma. And the third, this is when it is into the germinal state, right? Into the germinal state. And that is the seminoma in case of testis, right? In case of testis. In case of ovary, it is called as dysgerminoma, right? Dysgerminoma. All are OMA malignancies, right? So that is ovary. And when it is in general, right? Extragonadal, right? These are gonadal, testis and ovary, they are gonadal. When is extragonadal outside, it is called as just the germinoma. We learned it in 12th. Okay. No, I'm asking from the medical, after you took the admission. Human embryo. So this is extragonadal. But even in 12th, right, it must have been reasonably good. Anyway, we'll have one session on that also. And then I'll give you the links which are already put it into our cell. Okay, no worries, no worries. Chalo. Right, so this page would make complete sense as we'll start discussing the embryo. Let's come back to our anterior mediastinal tumors, right, over here. Now see, this is a CT scan, right? Now, why the CT scan is looking like this? Well, in CT scan, you can manipulate the image, right? You can change the contrast, you can change the brightness so that that specific area of interest, it can be enhanced, it can be seen properly. Now over here, very clearly you can see that yes, this is centrally situated, crystal clear, a completely well defined fluid filled, right? This is with water density. How do you know that it is water density? Because density can be measured in the CT scan, right? So this is a completely, it is a cyst. Why? Clear fluid, right? Clear fluid, water density, right? It is the water density. Yes, that's right. It is water density. So this is very typical, right? Just remember, and it is centrally situated, right? Centrally situated. No doubt about it. This is typical thymic cyst. And once you take the CT scan plate and being in first year, you watch it and you say, this is clearly defined thymic cyst, right? Rest of the audience will faint, right? More is yet to come, and see how easy it is. The next, trust me, all of you will be able to diagnose the next CT scan, right? Here it is. Here it is. This is once again another CT scan, and we are looking at this big mass, right? It is pretty big mass, right? Pretty big, pretty big. And this mass, right? This is all this. They are cystic, right? Water density. There is water density. Wait. Why lymphoma? Why lymphoma? Can you see? That's why I tricked you a bit. Can you see a septa? Another septa. Another septa. Right? See clear septas. Can you see? Right? See, these are septas. See? Right? Septa means partitions, right? All the way from one end to another end. So if I just unzoom it, you'll be able to see it still more clear. See, can you see it? Right? See how good the septa is. Septas are thin, right? Septas are thin, enhancing septas. If there is a tissue, so that would be thicker. That's why this is a germ cell. Very right. This is a germ cell tumor. Right? So these are like, we'll write enhancing septa. Right? And whenever the enhancing septas are there, this is beyond doubt, this is a germ cell tumor. Right. Next one. Watch this. So we are now dealing with, beyond doubt, we are dealing with this area. This is something which is not in center, right? Yeah, GCT. That's right. GCT, or the germ cell tumor. That's right, Sally. Now we are dealing with this structure. The structure which is not in center, right? It is on one side, but the looks itself is telling something that this is not as cystic. There is some cyst, but then there are all these, see, so many mixture, right? Mixture, mixture, mixture. So that is where the solid components are also there, right? So this area, and this one, this is cystic, plus there are solid components. True? Solid components. So that means this is, and by look, you can say that it is into anterior mediastinum, right? So this could be cystic thymoma, or it could be lymphoma. True? Or it could be lymphoma. From the looks, from the size of the lymphoma is pretty huge, right? But maybe it is the initial stage, but because the solid components have developed, so chances of being cystic thymoma, they are much more, right? Which it has displayed slightly. So you have to see the upper and lower cuts also, so that you can see the extent, the total extent. But say, even if you say it like whether it is cystic thymoma or it is lymphoma, right? That's, so things are clear. Then accordingly, you go for the further diagnosis, right? You go for PAT or whatever. Okay. How do you differentiate whether it is water filled or something else? Computers are at our help. CT. Computerized tomography, that is where you can put the cursor and you can measure the density, right? So when we'll be discussing the CT, at that point we'll be discussing at length about what is the water density, what is the blood density, right? We'll see that what is the tissue density. So all densities, right? There is a complete see, the graph is available, right? So where you can watch the density. So it is from the density which you measure digitally, electronically, with the help of, say, that panel, and you'll be able to see whether it is filled with what. Even if there is blood, you'll be able to figure it out. Achha. Now we talk about one more interesting thing, and that is what is called as the mediastinoscopy, right? It is called as the mediastinoscopy. Scopy means to watch. Mediastinum means you want to watch mediastinum. So basically, this is a surgical diagnostic procedure. Diagnostic procedure, right? What you really want to diagnose? You want to really diagnose that carcinoma of bronchus, it has spread to what level, right? So this is diagnostic procedure for spread of CA bronchus. CA bronchus. So what do you really want to see? Classical tracheobronchial lymph nodes. You want to see tracheobronchial lymph nodes, right? From now onwards, we'll write lymph nodes as LN, because these lymph nodes, every time we have to, this will come again and again, right? So we'll write it LN. LN is lymph nodes. We want to see these tracheobronchial lymph nodes. So a small incision is made in the midline. This is just above suprasternal notch, right? This is the sternum, suprasternum. So that's where a small cut, right? This is the suprasternal notch, right? A small cut. Why we put a cut over here? Because when you put a cut over here, right, we can explore the superior mediastinum, and that is where we can just go down, right? We can go down, just put a cut, and then you see that whether these lymph nodes are involved or not. So this is where the incision, right? The incision is put, and this procedure is called as the mediastinoscopy, right? Mediastinoscopy. Achha. Now we must talk about a very interesting thing, that is pleural effusion. Pleural effusion. Yeah, under anesthesia, so not painful at all. Under anesthesia. So pleural effusion, right? Now pleural effusion is what? This, right? This is our parietal pleura. Now you know it so well. And this is the visceral pleura, right? And in between the fluid, that is the pleural fluid, right? It is pleural fluid, and this fluid is really very less, right? Just about 5 to 10 ml of this fluid, right? It is there. Everything is fine, and this much is a very small amount of fluid, and keeping that pressure proper and keeping the lungs healthy, good, everything fine. Why it happens? Because this is not a dead fluid, right? A fluid which was kept right from the birth and but remains till the end. No, this fluid is secreted and then it is constantly absorbed. Wonderful mechanism is there, because see, there are capillaries over here, right? There are capillaries over here. So the capillaries which are onto the parietal part, right, they are systemic circulation. True? This would be the systemic circulation. Systemic circulation. Correct? On the parietal side, all those intercostals. Visceral pleura, this would be the pulmonary circulation, right? From the lungs. Pulmonary circulation. So what really happens in this case is that the pressure, the thing what is called as the hydrostatic pressure, right? The hydrostatic pressure. Hydrostatic pressure, this is a very interesting principle, of systemic circulation is definitely high as compared to bichara pulmonary circulation, right? There the pressure is not that high. So here the hydrostatic pressure is less. So that's why the fluid which is coming out from the systemic circulation can easily be absorbed, pushed into the pulmonary circulation, higher to lower pressure, right? So it can easily be pushed. So circulation over here is the fluid, and fluid goes, it absorbs new fluid, keeps on coming, and the new fluid, it keeps on working. This is 5 to 10 ml is maintained. All good. Life is fine. Now something goes wrong. What can go wrong? We want that pleural effusion is what? The abnormal accumulation of pleural fluid, right? Of pleural fluid. This is what really happens in pleural effusion, right? How much more, right? 300 ml. 300 ml, it should be accumulated, then and then it will start giving radiological appearance, right? Radiological appearance. Now you'll say 300 ml. Well, at times it is in liters, right? So we'll see that. Why should it really occur, right? Just understand this one principle and you will find pleural effusion so interesting. Simply, this is what? This is your systemic circulation, right? This is your systemic circulation. Who is handling this systemic circulation? You'll say, obviously the heart, right? So if this systemic circulation, if this pressure is increased, so then there would be so much of fluid generated, so much fluid that there is overproduction, right? The inner aspect of this is the pulmonary circulation, right? That is where there is a visceral component of parietal peritoneum. This one is parietal, right? Visceral won't be able to absorb that much, so there would be over accumulation of that fluid. So this systemic circulation, it can be maybe because of congestive heart failure, CHF. That is one of the commonest thing. Or when there is inflammation, right? The inflammatory things. So inflammatory component. Or when there is malignancy. So in all these cases, the systemic circulation is affected, so there will be overproduction. Against that, if everything is fine, but there is decreased absorption, unable to absorb. Now for this, there has to be a local cause, right? It has to be a local cause. Something should go wrong to the lungs. Commonest, collapse of lung collapse. So lung has collapsed. So that's why this surface has decreased. It is unable to absorb, so that there is increase in this. So these are the commonest commonest thing, how they can really occur, right? Now, okay, let me add one page, duplicate page. And you'll come across some names. You'll come across some names, right? When the fluid is serous, clear fluid, right? Simple. So then we say is the hydro, right? So it is called as the hydrothorax, more fluid, right? When there is blood, so it is called as hemothorax, right? When there is pus, so it is called as pyothorax, or at times even empyema, one and the same thing, right? When there is chyle, right, very rare, right, very rare, so it is chylothorax. Now, when we were telling about this part, right, the type of fluid over here, it would be transudate. Just remember this much. And if this is the pathology, it would be exudate. Right now, not talking much about it because it is massive topic. Right? But one day we'll definitely be differentiating between this. But at least remember this much, and it would be wonderful. Right? Let's see those X-rays. Here it is, the first one. Right? Why the patient is like this? This position is called as the lateral decubitus. Lateral decubitus position. This is one of the best position to detect pleural effusion at very early stage. Let's see, when the pleural effusion is there, right? So this is what? This angle is obliterated. That costophrenic angle is obliterated. Why to guess? Here it is. See? Right? Normally the lungs are like this. This is the diaphragm, right? This is the cardiophrenic angle. This is the cardiophrenic angle, right? Cardiophrenic angle. And this one is costophrenic angle. This is how the costophrenic angle looks like. This is normal, right? Yeah, so much fluid, exactly. And over here, right? See this? This angle is totally obliterated, and you can watch this is the fluid level, air fluid level, right? So this is a very advanced stage, but this is how it looks like. But if you want to diagnose it in early stage, here it is, right? So this kid, in this case, it is the lateral decubitus position. So patient is lying, right? Patient is like on the bed, on the X-ray table, right? Here is the head, and patient is lying on one side, right? Patient is lying on one side. So fluid gravitates, right? When the fluid gravitates, you'll be able to see this fluid level very cleanly, right? So when this distance of A, right, it is seen over here, and this tells that yes, this is the case of pleural effusion. One interesting thing, this lateral decubitus position is useful for two purposes. One, that which side is down. So if you on your plain X-ray you suspect that there is pleural effusion, let's say on the left side, right? So then one should be on the left lateral, right? So this left side should be down, right? Makes sense, because fluid will gravitate towards down thing, and you'll be able to see the fluid. But if you are diagnosing pneumothorax, right? If you're diagnosing pneumothorax on plain X-ray, you see the pneumothorax and you want to watch that, so you can take a lateral decubitus position, but in that case, the side where pneumothorax is suspected, that side should be up, side B up, right? Pneumothorax side should be up because it is air, so it will go up. So you'll be able to see the things over here. That would be in case of pneumothorax, right? So in pneumo, it would be here, and it is in the case of pleural effusion, it would be like this, right? No doubt about it, these X-ray chest always be taken, do remember, in the state of full inspiration, right? This is just to remember, right? Always remember this. X-ray chest to be taken in full inspiration. Yes, we saw this thing, right? Clearly, right? A massive pleural effusion. Watch one more. See here, relatively less, but still it is quite high. What you will watch very crisply is this fluid level, right? It would be like this. See, again over here, a beautiful fluid level. That curve. This is what is called as the air fluid level, right? So this is the fluid level. Same way over here. Okay? So much of fluid. That's how it really looks like. Achha. The final topic for today, right? It is what is called as the pleurisy. Pleurisy. Why is it a curve? Because see, you take a test tube, right? You take a test tube, any space which is a close, right, small space. You put the water into it. The water won't be like this, right? Because of the surface tension, water will be like this, right? It will be acquiring. When we'll watch from the side, it will acquire this position. Basically, this is a very narrow space, right? And the fluid, this is how the fluid will be taking its shape, right? Coming on to the pleurisy. Pleurisy, it is also called as the pleuritis, right? It is an itis. Pleuritis. Itis is inflammation, right? So whenever there is inflammation of pleura, that is what is called as the pleuritis, inflammation of pleura. Now it could be primary or it could be secondary, right? Primary, so then straight away, this is the infection, straight infection of the pleura, or it could be secondary. Secondary, that means it is occurring because of something else, maybe because of inflammation of lung. That is what is called as the pneumonia, correct? Pneumonia. So inflammation of lung, that can lead to inflammation of pleura, possible, right? Now, whatever may be the reason, due to this, the surface, right, surface of pleura, as such, it is pretty smooth, right? Now it would be coated with what is called as inflammatory exudate, right? It is called as the inflammatory secretion, right? Inflammatory secretion or inflammatory exudate. So it is coated with it, coated with. Now this exudate, right, it leads to the surface becomes rough, right? Now the surface becomes a rough surface. When the surface becomes rough, say in our body, lungs, heart, great vessels, right, there is always a rhythmic pulse. There is a musical pulse, right? Lungs also expand and goes down, expand and goes down, right? So this rough surface, when the things are smooth, so it is very smooth, there is no sound. When the surface becomes rough, it leads to what's called as the pleural rub. And this is in association with the respiration. So when you put your stethoscope, when you auscultate, right, when you auscultate, you'll find that during inspiration and expiration, right, as if something is getting rubbed, right, rhythmic with the respiration, right, rhythmic with respiration, you'll be able to appreciate it, and that is what is called as the pleural rub. Now later on, what happens is that this pleura, right, when there is exudate, when there is inflammation, so it will call fibroblast, that there is inflammation. So fibroblast, you have to come. When fibroblasts, they will come in large number, they will lay collagen, right? They will lay collagen, right? That collagen will bind to visceral pleura, right? This collagen will bind to visceral pleura. See, that's why these infections, they are so dangerous. It will bind to visceral pleura, right? And that visceral pleura and the parietal pleura, right? They will bind together. Once they are bound together, that is what is called as the pleural adhesions, right? Because it is like a fibrosis, right? Pleural adhesions. And that is what restricts the movement, right? So that is all because of fibroblast. So this is pleural adhesion. So that's it for today, right? Tomorrow we'll be dealing with more CT scans, more images, and we'll be focusing on pneumothorax, type of pneumothorax, and specifically the lung conditions, right? Okay, so thank you so much. What you want me to explain this adhesions? You want to? I can explain, no problem. But adhesions you are talking about? Last topic, adhesions. See, this pleurisy, also called as the pleuritis. Pleuritis, itis. Itis is inflammation, right? Inflammation of what? Pleura. True. Either it could be primary, right? Or it could be secondary. So straight away the infection in pleura or the infection of lung, it has been transmitted, and that is the pneumonia, it has been transmitted to pleura. Whatever may be the reason, surface of pleura, right? That because of infection, the inflammatory exudate it comes. It is coated with inflammatory exudate, inflammatory fluid, right? And that roughens the surface. Surface is rough. So now when there is respiration, right, and you auscultate, right, with the with the stethoscope, when you auscultate, when you hear, you'll be able to hear what is called as the pleural rub, right? Pleural rub, inspiration, expiration, both, right? As things go worse, fibroblast, they will invade, right? They will invaded by fibroblast. There will be lots and lots of fibroblast, right? These fibroblast, they will lay collagen. This collagen will bind visceral pleura and parietal pleura together. So now they both are bound. And that is what is called as the pleural adhesions. Pleuras, they stick to each other, right? So there is no that relative movement between both of them, that is lost. And this is called as the pleural adhesions, right? So thank you so much. And why do fluid filled cyst form? Multiple reason, right? These cysts, sometimes they are maybe because of some injury, infection, right? Maybe some abnormal activity. So all those things, right? In general, right? I'll tell you, in medicine, say congenital, traumatic, inflammatory. Remember this thing as a mantra. Inflammatory, neoplastic, miscellaneous. In miscellaneous, autoimmune disorders. Over here, it is benign and malignant. And in traumatic, it is surgical or accidental. 1, 2, 3, 4, 5. the entire medicine cause of almost anything, it can be divided under these headings. And if we stick to these headings, you'll find that say cyst, well, some of the cysts, they can be even congenital. They can be formed even by the surgical trauma or accidental trauma. Inflammatory, yes, it can happen. Neoplasm, in that case, it is not a clear fluid filled cyst, right? There would be formation of those solid structures, right? Or autoimmune disorders. These are the things which are in miscellaneous. You can add anything which is not into any of the above topic, right? So do remember this, very helpful. Okay, so thanks a lot and see you tomorrow for the next session of this clinical thorax, right? Thanks a lot and see you tomorrow. Bye bye.